that time when it is mostly blue before it becomes the night time. So this was taken during the last eclipse that was last week.
Blood moon.
So we are never alone, we are wolves howling to the same wolves. So at school is the wolves because so yeah. So this is half of the eclipse already at that time. So the adrenal glands are routinely imaged in patients with known malignancy, especially lung cancer, in order to detect metastatic disease. In patients with adrenal endocrine syndromes diagnosed clinically, imaging is used to find and characterize the causative lesion. So, multi-detector CT remains the imaging modality. So, the adrenals are composed of the outer cortex and the inner medulla that are functionally independent and anatomically distinct. The cortex secretes steroid hormones like the cortisol, aldosterone, androgens, and estrogens, whereas the medulla produces catecholamines. Okay, so cortex. So just note that cortex. The cortex refers to the corticosteroids. Cortex, corticosteroids. So that's one way to remember them. So what are the corticosteroids? They are called cortisol, aldosterone, androgens, and estrogens. The medulla produces the catecholamines. So there are some syndromes referable to the adrenal endocrine syndromes. So first is the Cushing syndrome, caused by excessive amounts of hydrocortisone and corticosterone released by adrenal cortex. So since these are steroids, so coming from the cortex. So the clinical signs include hypertension, truncal obesity, easy bruisability, generalized stiffness, diabetes mellitus, and oligomenorrhea. There's a children's fable, di ba? What's the round guy who fell from the wall? Humpty Dumpty, di ba? So, Cushing syndrome it looks like that. No? Truncal obesity, thin ang limbs. No? So, basic to si had model ato sa iya sa una was probably having Cushing syndrome. Then opposite to Cushing syndrome is Addison's disease. It refers to primary adrenal insufficiency. So this one is excessive, Cushing. Si Addison's naman kulang, no? Which occurs only after 90% the adrenal cortex is destroyed. So when the adrenal cortex is destroyed to about 90%, then Addison's disease may occur. Then another syndrome would be pheochromocytoma. This is a rare catecholamine secreting tumor that causes hypertension, headaches, and tremors. Paroxysmal attacks are characteristic but not always present. So according to the book, it's rule of tens. 10% are bilateral, 10% are extrarenal, 10% are malignant, 10% are familiar, and 10% are detected as incidental findings, and can be associated with multiple endocrine neoplasia. And this is the most common adrenal tumor, to spontaneously hemorrhage. So there's a risk of bleeding for this tumor. CT is the usual imaging method of choice. By the way, the adrenal glands are very difficult to visualize in ultrasound. ultrasound because it is covered with fat, and you know that ultrasound fat doesn't allow sound waves much to travel through fat. So for the renals, CT multi-detector CT is the imaging modality of choice. No? For ultrasound, it's very difficult to see. No? It can be seen, but it's difficult. It is better with a CT scan or MRI. So the kidneys, the CT urogram now is performed with multi-detector CT, supplanting the traditional intravenous pyelogram as the imaging method of choice in the evaluation of hematuria. So I haven't done intravenous pyelogram for a very long time. It's more than 10 years, I think. With the advent of CT, so CT has replaced IVP for this examination of kidneys. So it offers optimal evaluation of renal parenchyma with satisfactory assessment of the collecting systems, ureters, and bladder. So IVP, in contrast to IVP, it is a conventional radiography. It has higher spatial resolution, but unfortunately, we're not doing much of IVP these days, but this can still be done. But clinicians have not often requested for IVP these days. So, what is IVP? This is referred as intravenous pyelography or expiratory urography, studying the renal parenchyma, pelvocalycial system, ureters, and urinary bladder. So it involves injection of dye into the vein and taking a series of X-rays, beginning with the nephrogram, then expiratory phase, and then down to filling of the urinary bladder. But this has been largely replaced by CT urography. I'm not sure if the clinicians still know that there's still such a procedure as IVP these days. No? So this is an example of the IVP where the dye is already in the collecting system. So opacification of the kidney is called a nephrogram. So this phase, it is already in the excretory phase when the dye is already being excreted into the collecting system. So this is CT scan. Notice that in IVP there's a sharp demarcation of the collecting system and compared to the CT scan. So IVP has more sharper spatial resolution than CT. The MR urogram is also a high quality substitute for CT urogram. It is especially useful when CT is equivocal or when intravenous contrast should not be administered because of impaired renal function. So when you need to do imaging study of the kidneys and the patient is having renal failure already, the creatinine is very high, so you cannot give the contrast, intravenous contrast, because intravenous contrast, it is being processed and excreted in the kidneys. No? So when there's impaired function, so you cannot have the contrast. So the best substitute would be the MRI urogram. So these are the indications for ultrasound. Ultrasound is, these days, ultrasound is being requested left and right, for whatever conditions. But for kidneys, these are usually the indications: abdominal pain or flank pain referable to the kidneys. When you have hematuria, UTI, but in UTI, simple UTI, there's not necessarily, you will also find problems in ultrasound. So simple UTI, you don't usually find any pathology in ultrasound. And for suspicion of renal stone, renal injuries, congenital anomalies. So ultrasound has high accuracy diagnosing disease, stones, and hydronephrosis. So diagnosis for these conditions is usually enough for ultrasound. So this is how a kidney would look like in ultrasound. It is usually darker than the liver. And this mark here is the pyramid. You won't be able to appreciate it from here or from the monitors, but usually when you measure the cortical thickness, it's from here to just about the above the renal pyramids. But in practice, I usually measure the parenchyma. So here, if the pyramids are difficult to differentiate, the parenchyma thickness can be measured instead. So this is what I usually measure. So it's the parenchyma instead of the real cortical thickness. Cortical thickness is just this part here. And then, so this is the parenchyma. So this is the central renal sinus. It is echogenic. It is white. This is where the calyces are. These are the calyces, the renal pelvis, and there is more fat. So that's why it is echogenic than the cortex. So that's how a normal kidney would look like in ultrasound. For the congenital renal anomalies, the horseshoe kidney is the most common renal fusion anomaly. The lower poles of the kidneys are joined across the midline by fibers of parenchymal band. So look at this. This is the right kidney. It is joined with the left kidney with the fibrous band here in the midline. And kidneys are directed medially instead of kidneys are like this normally, but in fusion anomalies they are inverted. Then for solid renal masses, the renal cell Ca accounts for 85% of renal neoplasms, and common in men with 3 to 5 ratio, and usually presents at the age of 50 to 70 years old. So these are the predisposing conditions. So here on ultrasound, there's a mass in the right kidney. There's a mass, and on IVB, so it's a vascular mass because look, the contrast in the vessels fits into the mass, so you can see it has some vascular network also. Lymphoma. The primary renal lymphoma is rare, but the kidney is commonly involved by direct invasion from retroperitoneal lymphoma or by metastatic lymphoma. So primary lymphoma is rare, but metastatic lymphoma are common from spread from the retroperitoneal peritoneal lymphoma or lymphomas from other parts. So here, this is an example. But on ultrasound, you cannot actually say that this is lymphoma from other mass. But it's enough to identify that there's a mass. Then it would be up to you to further investigate it, go into CT scan or MRI, and finally for biopsy to determine whether or not this is really malignant or benign. So as to metastasis, the kidneys are frequent site of hematological metastasis. So most are detected late in the course of malignancy. So these are the conditions that metastasize the kidney, the lung, the breast, colon carcinoma, and melanoma. So just remember. Just remember these are the common metastatic lesions to the kidneys. But for just from ultrasound alone, you can differentiate this mass with lymphoma or renal cell carcinoma. Simple renal cyst is the most common renal mass. You can see large cysts, which can cause obstruction, pain, hematuria, or hypertension. So this is an example of a simple renal cyst. So take note, it is black. So it is anechoic. So there's no echoes within. Anechoic means there are no echoes within the lumen. And you can see it's very white here. This is what we call the posterior wall enhancement. When you have a cystic structure, so the sound waves passes through it, and so you will have a white posterior portion because of the sound waves passing through it. Contrary to the stones. So the stones, posterior cornea is black because there are no sound waves passing through the stone compared to the cyst. So there's some criteria for simple renal cysts are they're round or oval and anechoic mass. So they increase through transmission. So this is through transmission. Sharply defined far wall. So the wall is sharply defined. Thin or imperceptible cyst wall. So the cyst wall is very thin. So another example here. So that's an example of simple renal cyst. These are commonly seen on ultrasound, especially in older patients as part of degenerative process. Then you have complicated cysts. These are simple renal cysts that may become complicated by hemorrhage or infection. Resulting change in imaging characteristics may make differentiation from cystic renal tumors difficult. So this is now a complex renal cyst because there are some echoes within the cyst. So here, this is an example of hemorrhage within the cyst. When the urinalysis reveals some hematuria, then most likely this could be hemorrhage within the cyst. With renal abscess, it usually results from pyelonephritis, complicated by liquefactive necrosis of the renal parenchyma. So this is an example of an abscess. You can see it there. There's a mass, anechoic mass, and so you have to know the history of this patient when a patient exhibits fever, usually high-grade fever, patient is relatively toxic, relatively very sick. So to differentiate it with the simple renal cyst or the complicated renal cyst with abscess, with a history of fever and other symptoms, then this is most likely an abscess, and you have to correlate it with urinalysis when you have pyuria, high WBC in the urine. So this is most likely an abscess. So when you look at the ultrasound, you see this, then you have to check on the chart for other symptoms before you can definitely say that it's a renal abscess. You may see pictures of kidneys like this, multiple cystic structures, mostly replacing the kidney. Also, this kind of, on CT scan, this kind of picture. Then you have some, either the autosomal dominant polycystic kidney or recessive polycystic kidney. So this is an example of polycystic kidney. So, of course, it is in autosomal dominant because the inheritance is dominant, autosomal dominant inheritance. Usually manifests clinically later in life. Renal parenchyma is progressively replaced by multiple non-communicating cysts of varying sizes. So these are non-communicating cystic lesions, diffusely replacing the kidney. And most patients present clinically between ages 30 and 50 years old. So autosomal dominant polycystic kidney presents between 30 to 50 years old. Whereas in recessive, autosomal recessive, they are seen as early as neonate and in the fetus. So between how it looks sa ilang duha, it's hard to differentiate. But you have to know that dominant is in the adult age, recessive is in the neonate and fetus. So when you see polycystic kidneys in the neonate and in the fetus, then it's most likely autosomal recessive polycystic kidney. Sometimes on X-ray, accidentally you will see this kind of calcifications in the X-ray, and then when you request an ultrasound, the ultrasound will look like this. So this is a medullary sponge kidney, referring to this plastic dilatation collecting tubules in the papilla. So there's urinary stasis in the papilla resulting in stone formation. Stones in the papilla cause increased echogenicity ng medulla ng ultrasound. So mo na siya ang medulla. This is here in our setting, we call it medullary nephrocalcinosis. It is a relatively common disease. I see it from time to time. So when you see this kind of ultrasound, you have multiple patches of white areas, but there are no strong. With this size of white, there should be a very strong tail. This is purely stone, but there's no posterior tail. So this is most likely nephrocalcinosis. In acute pyelonephritis, it is ascending urinary tract infection caused by gram-negative organisms, especially the E. coli. So You might wonder why UTI is more common in women because of the proximity of the two openings in women, no? the urethra and the anal canal. So for women, don't wash from back to front, no? Wash from front to back. Okay, so because if you're going to wash from the back and bring it forward, then you are introducing the fecal coliform into your urinary opening. In uncomplicated infection, it usually requires no imaging, often shows no imaging abnormalities. Imaging evaluation indicated in patients who fail to respond to treatment or are severely ill. CT is more sensitive than ultrasound in demonstrating subtle changes in the renal parenchyma associated with uncomplicated pyelonephritis. Usually in ultrasound, pyelonephritis, the only indication that there could be pyelonephritis going on is because when you see large kidneys and they are usually very, very dark than the usual parenchyma that you see. You know? Here, it is very dark, it's almost black, and if you measure this is in large size. And sometimes you may have this heterogeneous parenchymal echo pattern. So these are the only changes that may suggest pyelonephritis. And of course, you have to correlate it with your laboratory findings, like the urinalysis. When you have pyuria or high WBC count in the urine, then that confirms your diagnosis of acute pyelonephritis. Emphysematous pyelonephritis, though I saw some cases of this in practice. Emphysematous pyelonephritis, emphysema means there's air in the kidney. So it is a form of pyelonephritis with gas in the renal parenchyma. Most cases occur in patients with diabetes, obstruction often caused by calculi or immune compromise. It is rapidly progressive and destroys renal parenchyma and is often life-threatening. So on ultrasound, you will see this. There's some shadowing, but the echogenicity is not solid, like in a stone. So it's like hair. So that the posterior shadowing is like a hair or waterfalls. So you may consider emphysematous pyelonephritis. So another example here is like waterfalls, ang yung posterior shadowing. So you will consider this as probably there's air within the kidney, so it's emphysematous pyelonephritis. So renal TB may follow primary TB by as much as 10 to 15 years. It's hard to say that this is TB just on ultrasound alone. So the urinary tract is the most frequent site of extrapulmonary TB, and patients present with asymptomatic hematuria or sterile pyuria. When you see this kind of ultrasound, you suspect of pyelonephritis, but then when you check on the urinalysis, there's absence of WBC. Or you may see some hematuria, so you may consider probably renal TB. So the hallmarks would be papillary necrosis, parenchyma destruction, and cavity formation leading to uneven atelectasis. So this is best seen in more on CT, and you're able to see more a better picture in CT than in ultrasound. So here you may initially you may say this pyelonephritis, but on urinalysis there's absence of pyuria, and patient may have TB in the lungs or history of TB. Then you may consider this as renal TB. But the first consideration would be always pyelonephritis, and then you work backwards. You eliminate the process of elimination, so you will end up most likely in renal TB as your final diagnosis. In renal failure, ultrasound is usually requested to assess the renal size, to exclude hydronephrosis, and to identify renal parenchyma disease. Patients with acute renal failure and large or normal sized kidneys often require biopsy for definitive diagnosis. And patients with small kidneys usually have irreversible end-stage renal disease and generally do not benefit from biopsy. So, measurements of renal cortical thickness are unreliable in assessing residual renal function. So here, this is a diseased kidney. It's very white compared with the liver. And if you measure this, if this is small, then this is already chronic. So it's probably already on the end stage. Here, this is still probably a normal kidney, and then later on you have heterogeneous kidneys and becoming echogenic kidneys. So this may be stages of renal failure. But when you see this very white kidney, then it's most likely in the end stage renal disease. And then when you check on creatinine, it's very high. Some patients have CREA of 20s, so they're very sick. Okay, so this was my travel when we went to Davao and passed through Marilog district. Usually the Marilog district area is foggy when it is raining. And sometimes you can see the low-lying clouds on the valley. So again, another shot of the moon. This is already half the eclipse. So be the moon and inspire people even when they're far from full. Pelvopharyngeal system. Pelvopharyngeal system is the collecting system of the kidneys. CT urogram is now the imaging method of choice for evaluation of hematuria and screening of examination of pelvic pharyngeal system and ureters. It is limited by lower spatial resolution than IVP, and retrograde pyelography is performed by cystoscopic catheterization of the ureteral orifice, followed by injection to contrast. So this is a retrograde pyelography. It's usually the urologist who does this in the operating room. So this is a cystoscope. Then the urologist inserts a catheter all the way to the kidney and injects a dye to see whether or not there's obstruction along the ureter. So as for congenital anomalies, the duplex collecting system or duplicated collecting system is one of the most common congenital renal tract abnormalities, characterized by incomplete fusion of the upper and lower moieties. So this is the upper and lower moieties. So there's incomplete fusion between the upper third and the lower 2/3 of the kidneys. In this case, it is bilateral involvement. So you can see that the upper moiety has its own ureter as well as the lower lower moiety have its own ureter and they insert in the bladder. Once considered anatomical variant, the duplex collecting systems may be complicated by vesicoureter reflux obstruction or ureterocele. So there's a law on the duplex collecting system, the Weigert-Mayer law. So with duplex kidney and complete ureteral duplications, as in the proceeding also, the upper and renal moiety is drained by separate ureters. The upper renal moiety has ectopic, so upper is ectopic and results in ureterocele. Okay, so take note, upper ectopic ureterocele. So that's how you remember the Weigert-Mayer rule. Whereas in the lower, so this is the upper, and you may not quite differentiate, but there's an irregular dark area that I labeled here. And when you do ultrasound in this area, you will see this. So this is the ureterocele. Okay? So it's not very clear here, but when you look at it very closely, there's a darker area here, and ultrasound will reveal this. So this is ureterocele. That's in upper moiety. Upper, ectopic, and ureterocele. Whereas in the lower renal, whereas in the lower moiety, it has normal insertion, but results in vesicoureteral reflux. So lower, normal insertion, vesicoureteral reflux. So this is the lower moiety, this is the ureter. Because usually the reflux is because of the obstruction of the ureterocele compressing on the normal insertion of the ureter, then you will have reflux, urine going back up to the kidney. So this is a picture of reflux, and this is the grading of reflux. So when the reflux reaches up to the level of the kidney, when you have a rounded collecting system, then that's already grade 4. Okay, so remember Weigert-Mayer law, the upper has ectopic insertion and complicated by ureterocele. The lower has normal insertion and complicated by vesicoureteral reflux. So that's how you remember the Weigert-Mayer law. So you don't have to memorize verbatim the law. Just remember these keywords. Upper ectopic ureterocele, lower normal reflux. So renal stone disease, nephrolithiasis refers to the presence of calculi in renal collecting system. So there's sufficient calcium oxalate or calcium phosphate. So these are usually the component of these calcified stones, the calcium oxalate or calcium phosphate, in 80% of renal calculi. So these are the components that make the stone radiopaque in conventional radiograph. So when you see this white stone or white spot here, then that's probably the renal stone. Usually acute flank pain is common complaint, seeking emergency medical treatment. Sometimes you have renal colic caused by calculus obstructing the ureter. So the stone has dropped into the ureter, and most common cause of acute flank pain is usual major consideration for diagnostic imaging. So this is ultrasound. There is a stone in the obstructing the pelvic outlet. So the renal pelvis is partially dilated, and you have the stone there. And it has a stain, posterior shadowing. So this is again ultrasound of the urinary bladder. You have this stone. On X-ray, you may see this kind of calcifications in the pelvic cavity. So those are stones. And here, this is most likely a stone in the kidney, because this is the kidney, and this stone is in that shadow. Hydronephrosis is defined as dilatation of the upper urinary tract, and ultrasound is excellent screening modality for determining presence of urinary tract dilatation. So these are the different grading of hydronephrosis. When you have a mild, just split sinus, so that's grade 1. When you have cases as dilated, so that's already grade 2. When it involves the ureter already and proximal ureter, grade 3. Then when it's already rounding of the calyces, then grade 4. And when you have parenchymal compromise, that means thinning of the parenchyma, then it's already grade 4. The causes of obstruction include stones, stricture, tumor, or extrinsic compression. In general, more proximal and more chronic the obstruction, the greater is the degree of dilatation. And ultrasound demonstrates hydronephrosis, a separation of normal sinus heterogeneity, and anechoic urine. So this is example of hydronephrosis. And most likely hydronephrosis is due to obstruction in the distal ureter. So pyelonephrosis, ang hydronephrosis is uncomplicated dilatation of the urinary tract. So with pyelonephrosis, there is an infection of the obstructed kidney. So ultrasound classically demonstrates a dilated collecting system filled with layering, epigenic pus, and debris. So this is an example. These are examples of ultrasound of kidneys. You have parenchymal disease. You have hydronephrosis here. Then here in this slide, you will see some debris, layering of debris. So this is already pus in the dilated collecting system. So that's when you see this, when you have layers of debris inside the dilated collecting system, then that's pyelonephrosis. In vesico-ureteral reflux, this is more common cause of hydronephrosis in children. The basic defect is an abnormal ureteral tunnel at the ureterovesical junction and associated with a urinary tract infection. When you see children coming back to you repeatedly for urinary tract infection, and sometimes the urinary tract infection doesn't resolve within the time that you are treating the patient, and multiple times, several visits to your clinic, still the same. The cause of, you have to investigate the cause of UTI, and most probably this could be the reason, because of reflux, because of the abnormal uterine tunnel ureterovesical junction. So do an ultrasound, check whether the patient has hydronephrosis, and if it's not, it's equivocal in ultrasound, then you have to do some contrast studies like IVP, CT urography, or retrograde pyelography to determine whether or not there's actually a reflux in your patient. So, in the urinary tract system, we have some common, what they call this, malignant new growth. The transitional cell carcinoma accounts for 85 to 90% of all uroepithelial tumors and is the second most common primary renal tumor, renal malignancy. So, transitional cell carcinoma is the second most common primary renal malignancy, and it is most common of the uroepithelial tumors. Then you also have squamous cell carcinoma, which is only 10% of the tumors. They are usually infiltrating and spreading, producing stricture or subtle filling defects. Imaging appearance is indistinguishable from transitional cell carcinoma. So, squamous cell carcinoma and transitional cell carcinoma are different to distinguish in imaging modality. So, biopsy would determine, would differentiate them from each other. So you may see also metastasis, but they are a rare cause of collecting system mass. So they are commonly from the breast, melanoma, lung, stomach, and cervix. So these are primary tumors that metastasize in the kidneys. So again, I was able to watch the eclipse up to the last quarter, the eclipse, but since there's thick rain clouds that time, so I could not take complete pictures. Even the red moon, I had a hard time taking a picture of the red moon because of the clouds passing between the moon and my camera. So this is already the eclipse is already. This is after the eclipse when the eclipse is already moving. So this is my camera setup. I stayed up to 3 o'clock in the morning. So even a man who is pure in heart and is praised by night may become a wolf when the wolf wing blooms and the moon is full and bright. So kung binisayan ko na ito, kung bulan ng yun mo, tukar din yung topak. Sa manan siya. Kung bulan ng yun mo, no? So kung full moon, katong mga bulan ng na ayaw pagawas. Okay, so this is a chance photojournalism. This was still back in mid-2000 when the Venice Street is being constructed and being cemented. So this is an example of a road bridge. This is in front of Polymedic Plaza. This is a jeepney driver, this is a taxi driver. So since there is a one-way, this is a one-way lane. So I don't know who got into the lane first, but since they figured they cannot move around, so nag-away sila, and then they hit each other with rocks from the construction, and after this, they went inside Polymedic Plaza for treatment. So I'm going to sila. This is an example of road rage. So to ganyan siya picture made, I forgot what year the Venice Street was being cemented. So nagawas na ko ani from reading x-rays from Polymedic, and I chanced on this encounter. So muna, anger like fire dies out after leaving a path of destruction. So, kung when you are angry, so try to compose yourself. Okay, abot mo aning ang kwan, it leaves a path of destruction. So, ano makita mo karon sa rally, no? So, wala may pulse na itong mga rallies kay ilang kasubot ito man i-call sa mga on other people like the police. Actually, the police are not our enemies. No? They're just holding they're just enforcing the law, but they're not the enemies. Okay, so that ends our first part of the series, and then Friday